All right, well, let's get started. I want to thank everyone for joining us for our second session of the CPH review session series brought to you by the National Board of Public Health Examiners. My name is Ashley Mueller, and I am the Manager of Educational Programs at NBPHE. We're excited for you to be here and celebrate our 15 years with us, as well as help prepare you for taking the CPH certification exam. So just a few logistical things about today's webinar that I mentioned in the first one, but I'll mention again today. I'll be monitoring the chat and Q&A throughout the presentation. So chat is open for you to interact with the other audience members. If you have a question for our presenter, please make sure to use the Q&A section so that we see it and our presenter will answer the questions at the end of their presentation. I did see a question already about the recording, and yes, we are recording all of these sessions. And they will be available the day after each of the sessions. So the link will go out via Zoom in an email just like you got before today's session. So please look out for that. Also, as I mentioned last session, we are giving away the APHA CPH exam review book at each session. So last session, our winner was Amanda Phillips. She won a copy of the review guide, and we will be raffling off another copy today. So one attendee will get a free copy of the APHA CPH review exam guide. So now on to our topic. So today's topic is policy and public health, presented by Lillian Agbeyegbe. Dr. Agbeyegbe is your friendly community health educator. She's a compassionate public health educator, advocate, and community organizer, working on public health issues that disproportionately affect women and children, including HIV/AIDS, intimate partner violence, healthy housing, human trafficking, and other issues that are impacted by social determinants of health and complex systems. She's an expert at creating shared vision and building and sustaining collaborative partnerships for improved health outcomes. A member of the Maryland Public Health Association, she is currently co-chair of their communications committee and presents their Your Public Health Professional NEU program. She served on the Maryland Network Against Domestic Violence Board from 2017 to 2019, Court Watch Montgomery from 2015 to 2023, Howard County Coalition to Prevent Intimate Partner Violence since 2014, and She Rises International, Inc. since 2020. She is currently serving a third term on the Family Violence Council after being appointed by Governor Larry Hogan in 2015. She co-chaired the Healthy Teen Dating Work Group and the Abuser Intervention Program Work Group, and is currently chairs the Survivor Advocacy Council Work Group. At Polaris, a leading anti-traffic organization, Dr. Agbeyegbe wrote a Human Trafficking at Home, the Labor Trafficking of Domestic Workers report, and coordinated an upstream sex trafficking prevention initiative implemented in 9 cities across the United States. She was the MVDV 2022 Leadership Award honoree. In 2023, she received the citation recognition for outstanding community service from Governor Wes Moore. She also received the NBPHE President's Award for Significant Impact on Public Health in Maryland. Dr. Agbeyegbe is an adjunct faculty at Bowie State University, a historical Black university, where she teaches a graduate class in domestic violence crisis counseling. She's earned her doctorate of public health degree from the University of North Texas Health and Science Center and her master's in public health in community health education from the City University of New York, Hunter College. She earned her bachelor's degree in economics from the University of Laos, Nigeria. She is a certified health education specialist and is certified in public health. So with that, I'm going to turn it over to Lillian.
Hello, and thank you for being here today. I was just going over my presentation and I was like, oh, Ashley, I have some questions that I guess I have to use charts to answer because I didn't send some of those questions to you, but that's fine. But thank you all for being here. I cannot see myself. Am I on the speaker gallery?
Yes, I see you.
Yeah, okay, awesome. So let me share my screen and we can get started. Great. So thank you all for being here today. Everybody hear me good?
Yep, can you just put it in presentation mode? It looks like, yep, perfect. There you go.
Yes. That's in presentation mode, that's good?
Yes.
Awesome. Well, as you know, it's the certification exam, certification in public health. We have 10 domains: communication, leadership, law, ethics, public health, biology and human disease risk, collaboration and partnership, program planning and evaluation, program management, policy in public health, health equity and social justice, evidence-based approaches to public health. And this session is the session on policy in public health. Ashley has already told you a little bit about me, but I put this slide here to show some of the advocacy work and health education work that I've done out in the community. From Maryland, where I currently live and work, to collaborating with people across the country. So you see some work done in Louisville, some work done in Nevada, and the World AIDS Day work was when I was living in New York City. But for this review session, what we're going to do is look quickly at the 10 essential public health services, the CPH exam domains, which we have done. We will discuss public policy as a core public health function, outline the policymaking process phases. We'll discuss the factors that influence and challenge policy evaluation, and then we'll do some questions, practice sessions. So this question is the one I was saying we don't, so I'd have people answer in the chat. How familiar are you with public policy? Let me get the sense from the chat how familiar people are with D, D, B, D, D, D. So no work experience, previous work experience, some work experience. Somebody had C and D. Okay. Well, it's good that we have a very diverse audience in class today. We have some people who are, I haven't seen any A. Did I see any A? No. So I didn't really see anybody currently working in health policy, but a lot of our work is indirectly with health policy, and that's what applies to me. So as she said in my bio, I worked in various issues, HIV/AIDS, human trafficking, and all of those areas, even though they are not in health policy itself, because you're trying to make things happen in those sectors, you have to be working with policy. Well, we'll look at how all of that works in this presentation. So the 10 essential public health services, a lot of us are familiar with this work, and it tells us how we as public health practitioners are working. There's the assessment, which has those two sectors where you assess and monitor for public health and then you investigate. And then there's the policy development session, and that's where health and policy comes in. So you really want to communicate, to inform people, to educate them. You want to have all of those collaborations working together. And it's in through those collaborations that you will champion policy plans and laws. And then you utilize law and regulatory actions. And then you see the assurance is another component. So health policy features in the policy development place. So what is health policy itself? Uh, Let me get a sense of what people think health policy is. Can I get a sense in the chat about what does health policy mean to you? What is health policy? Anybody wants to take a STAB, planning, systemic change, creation of laws and regulation, moving health through illegal testing regulations, advocacy, dollars, any policy having knock-on effect, protecting the general public, legislation and regulations. That's Victoria is really closest to us. Governance, good. Well, we're going to go with the CDC definition in this presentation, and it talks about health policy as a law, regulation, procedure, administrative action, incentive, or voluntary practice of government and other institutions. So when people come together, you either have a law or regulation, it can be an administrative action. All of these tools are used to guide behaviors and practices. And there's a difference between law and regulation, which sometimes can be confusing for people. So laws really are implemented by the legislative branch of government, and we're going to look at the different branches of government later on. Laws are instituted by the legislative branch of government, and there are systems of rule created for the protection or promotion of community health. On the other hand, we have regulations. Those come from the executive branch, and those are a set of rules that describe the implementation of legislation. So it's important to notice this difference because when you see something in a law, it can be just like one paragraph, but if that law is going to be translated to regulations, you'll be surprised to see you have 100 pages for the regulation, because it will say in details when it says no person, then you have to clarify what you mean by no person, who qualifies as the people that are included in that category. So that's very detailed, and that's one of the difference between public laws and regulations. We want to now look at public health policy tasks, and there are about 14 tasks that the CPH domain recognizes that we should be involved in as public health practitioners. So develop positions on health issues, laws, and policies. You want to establish goals and timelines, funding alternatives, partnership opportunities for influencing policy initiatives. You want to defend existing health policies, programs, and resources. You want to really educate policy and decision makers on how to improve health, social justice, and equity. You want to use scientific evidence, best practices, stakeholder input, so public opinion data to inform policy and decision program making. And we're going to go into this in details. I'm just outlining the 14 sessions first. So these are part of it. You want to assess the position of key stakeholders for health policy, programs, and resources. You want to promote the adoption of health policy, programs, and resources. You want to identify the social and economic impact of a health policy and initiative. You want to analyze the economic policies and how they affect systems at the local, national, and global level. You want to manage changes in health systems. You also want to determine the feasibility and expected outcome of policy options. Analyze the policy options when you are designing programs. Various of you work in different places. Ensure the consistency of policy integration into your plans, and then really implement federal, state, and local regulation policies and guidelines. So let's look at, when we talk about developing the position of health issues and policy, there is a policymaking process. And the policymaking process as a whole is in six steps, and we're going to go through them. So I just want to make sure I'm not missing anything in chat. Okay. In 6 steps, and we're going to go through them. The first thing you want to do is agenda setting. If you want to, before you decide that this is an issue and we need to address it, you want to look at what is the problem and how do you get that problem on somebody's agenda, on the agenda of your organization, on the agenda of your partners. You have to identify the problem and get it on the agenda. After you've identified the problem and get it on the agenda, then you really have to say, okay, so what do we do to address this? Is there a policy solution? So if you take, for instance, when people looked at the relationship between tobacco smoking and cancer and say, okay, we want to do something about it. This is a problem. People are smoking and they are getting cancer. And then people decided we want less people to smoke. So a number of policy issues came out from that solution. Some of the policy issues was restrict the age of people who can buy tobacco. Some of it was create smoke-free public places. Some of it was increase the tax on tobacco. So you find the problem, and then you look at the solutions and then say which part of those solutions are dependent on policy issues. And when you've done that, then you now have your collaborators come together. You develop a bill that you take either at the state level or the federal level. You want to pass it in both houses, both the House and the Senate, and then get the bill signed by the governor or the president. Now, I shared this because right about this time, this is January, so a lot of states are beginning their legislative session, and Maryland is not left out. Here in Maryland, currently, we have the Maryland Legislative Action for Women. They are one of the lead advocate proponents in the state of Maryland, and they have put out this legislative action. So there are 9 bills that they're currently looking to share out. And this is what they're doing. I wanted to share this so that we can see. Okay, I'm going to share that so that we can see that. So if you see this is the legislative agenda for Maryland. They had a conference. I wanted us to look at this because this is what happens when you want they are promoting 9 bills that they want to sign, but look at how many people. They have the National Organization for Women, they have the Maryland Commission for Women, they have all of these North Arundel County Alumni Chapter. You can't pass a bill on your own. You need all partners to come together. Baltimore County Commission for Women, Yes We Can, Emerge Maryland, Women's Law Center, M-Law, Women's Democratic Club, Reproductive Rights are Human Rights, and they have different partners come together, Maryland Healthcare for All. And this is how you pass legislation. When it's time to work, MCASA, all of this is one program for one event. And I'm just sharing all of this for you to know the importance of having partners work with you when it's time to do a legislative session. And that's what's happening in Maryland currently. Maryland Legislative Agenda for Women is not the only person who's working on agenda issues in Maryland currently. This is the Maryland Public Health Association. And as you can see, in January, they've sent out a notice to their members. They're going to start having bi-weekly meetings because they have policies that they want to be passed during this legislative session. And the way to get the policy passed is to meet together and to strategize over it. So they have started to do that. So once you have your policy that has gone and either the governor or the president has signed it into law, it's no longer a bill, that policy has passed, is now a law. There's the policy implementation stage. This is the stage where you begin to say, how do we operationalize this? Where's the money going to come from? Who is going to finance it? So I give an example of a policy that passed in Maryland some time ago was if you're convicted of domestic violence, you have to turn in your gun. And for a long time, it was just a policy, and the judge will say, okay, you need to turn in your gun, but that was how far it went. And we had to go back and work with partners to say, there has to be a system. What happens now that we've passed a law and said, yes, you shouldn't own a gun? So now they have a policy in place in the state of Maryland now that not only does the judge tell the person that you do not have a right to own a gun, the sheriff office is there to make sure that they collect the gun from the person. So that's a next step. So who collects the gun? Then even when you collect the gun, who keeps the gun? Do they get their gun back? You have to work out how that policy is going to be implemented, not just that. You want to pass a policy and say, okay, fine, you can't own a gun, but now you've passed that law, what's the next step? So there's the policy implementation step. After that, there's the policy evaluation step. You know, how is the policy addressing the issue that has been identified? One of the things we found out after we even passed that law and said the sheriff's office should be involved in taking guns from offenders, we now found out that there was no tracking of the system. So we even had to go back again to say, pass another policy to say, this process has to be tracked. When the process is being tracked, it's going to enable us to see which county is really following, because this was a state law, which county is following this process. And that way you can find out that whether they're being successful in doing it. You now have to find out, is it the judge that isn't telling the people in court that this has to change? Is it the sheriff's office that isn't collecting the guns? Is it the people, what's following up with them? And I see a long comment, sorry, I wanted to read that many government health policy officers have little experience either in health science or service delivery. I agree sometimes that it's an advantage, but often it leads to excessive bureaucracy and policy catching up with practice rather than predicting and regulating health practice. This is one reading why health inequity persists and widens, in your own opinion. Absolutely. I have to agree with you that in your own opinion, that's why this is, but you see, that is the advantage of the brochure I showed you with all of those partners. Because what happens is when an organization is going on, you can have the solution. The researchers alone are not what we need. The researchers, we need them to show us the problem so that you can document. And when you're advocating for policy change, you have the data to show that you need this policy change. But you also need the implementers, and that's why we had the implementation. You also need the implementers to say, okay, how does this translate to practice? And after you have done that, you also have to evaluate to say, did it work? Did that policy work, or do you need a different policy? And that's what happens in the next page where we do the policy modification. So when you are doing an evaluation and you're following the stream of the system, then you can say, okay, this policy is working, we need to continue it. This policy isn't working quite well, we need to modify. Maybe the sheriff's office needs some additional support. Maybe the courts need to do something different. Maybe we need to partner with community-based organization to be in the system. What is the abusers intervention program perhaps that needs to be supplemented with the program? So there are different ways in which we do all of this. The goal, like we said, is really health for all. So we have to continue to monitor that. It is basically implementation science. I'm not sure what you mean by implementation science. What I'm saying about the implementation is when you pass a law, you can pass a law and say, okay, fine, we want, I'll give an example in the area where I worked. We do not want non-custodial parents and custodial parents to exchange children in an unsafe environment. So you pass a law and says that there had to be a safe exchange program. You've passed the law, but how does that get implemented? Where is the place that is going to be the safe exchange program? Who is going to man that office? Is it going to be manned by people from the Department of Health and Human Services? Is it going to be manned by another program? Which agency is going to be responsible for it? How are we going to get in touch with the custodial parent and the non-custodial parent? What is that facility going to look like? Do they have the same entrances? Do they have different entrances? Who comes in? And that's the policy implementation. It's not the law. The law has already passed and said, we found out that because people are exchanging children on their own, sometimes children get killed, sometimes partner gets killed. And so we don't want that to happen. And so we've advocated, and the law has now said there has to be a safe exchange place. But where is that safe exchange place? Where is it going to be located? Who is going to operate it? How many days does it operate? How do people access it? What's the responsibility of the provider? What's the responsibility of the custodial parent and the non-custodial parent? So it's just working out the logistics is the policy implementation place. And in that sort of policy, if after you do that, somebody gets killed at the safe exchange place, it's not a safe exchange place. So you have to go back to the drawing board and say, did we miss something in that policy? So that's how that system works. you do the policy, you pass the bill, and then you evaluate how you're going to implement it, and so to know whether you should continue with that work or you should do something differently. Now, when policies get into place, there's, in terms of developing positions, there's something that we call a window of opportunity. And it says it's a stream of 3 factors that have to be in place. When those 3 factors are in place, you are more likely to get a bill passed into law. So you have support among the voting public and policymakers that the problem should be resolved. You have support for the proposed policy design, and then the political relationship are receptive to change. Now, when you think about the gun laws in the country, for instance, anytime there's a mass shooting, there's always a mass outcry about, but where are we with gun laws, either at state levels or at federal levels? You can see that we haven't gone as far as public health practitioners would like us to go. And that's because there's a discrepancy. The window of opportunity hasn't completely existed for us to go as far as we would like to go with gun laws in the country. So those window of opportunities have to be in place. When they are in place, then we can bring policies to pass. But unless they're not in place, now this is some examples of when we looked at the window of opportunity. So in 1965, we passed the Social Security Medicare Act, and we successfully passed it. I wonder what people think. This is one of those places I'll look at the chart to see, do you think we passed it because the public perceived that the problem existed, there's support for the existing policy? A majority, what are people's thoughts? Let me see voting on that. D. Can you go back on the slide? I'm still on the slide. D. So yeah, I'm seeing a majority of D. I've only seen one B, so everybody's on it. And it is D. It is D. So the public perceives that the problem existed because at that time, the baby boomers were looking at it, and these people are going to age, and who's going to take care of them? So the public perceived that the problem existed, and then we're saying, okay, funding is going to come through the years. So that was the design of the policy, and people were like, yes, it's not a one-time funding for it. It's going to be money coming out from Social Security over the years. So we're going to have funding for it. A majority of Congress supported the plan as well. And this is when we talk about a window of opportunity. All of these things have to exist. And when all of these things exist, then we're able to pass the law. There's another policy that passed, the Affordable Care Act in 2010. Now let's look at it. Do you think that the Affordable Care Act passed because the policy was embraced by a majority of Republicans or majority of Congress, or the political climate was favorable? All of the above. So we're on to this. I see C, B, C, 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 B, D, D. Okay, we have more diverse opinions on this one. But it wasn't all of it's not D, it wasn't all of the political climate between Republicans and Democrats were not favorable because this was the time that President Obama was in office, and the Republicans was basically stalling everything that he was doing. It was B, the majority of Congress, because we had the Democrat president and the Democrats were, in the majority. So they were able to push it. But as we have seen that even though the Democrats were able to push it, then since then we've seen efforts to repeal Obamacare since then. But it passed at all. If you try to pass Obamacare now, it won't be Obamacare now, but if we try to pass the Affordable Care Act now, it probably won't pass. But at that time, it passed because the majority of Congress and the president were from the same party. So you have to have that window of opportunity where the solution, the people who are voting and the people who pass the policy are all in alignment, and you're able to get a bill to pass. Our government we probably know that there's 3 arms of government, and all of them are involved in laws and policies. So the federal legislative branch, which is Congress, they pass the laws. they control the spending, and a bill must pass both chambers, both at the federal and the state level. So even at the state level, a bill must pass both chambers. At the federal level, a bill must pass both chambers. And the Congress has the ability to override a veto, because once a bill passes both chambers, it goes to the president or the governor to sign. The president or the governor can sign it, or they can veto the bill. If they do veto it, though, it can go back to the chambers, and if 2/3 of votes in both chambers can override that veto. So we have a bill, we have an issue, we say there's a policy solution. Members of the community gather together, they propose a bill, they pass it in one house, they pass it in the second house, and then it goes to the governor, the president, and then they sign it. But after the governor or the president has signed it, then there's the judicial branch, where you actually have them contest these policies. And so you can go to the Supreme Court to challenge it. So we've seen that challenge with Roe v. Wade. We've seen all of that challenge with this landmark case for vaccination, and all of those. So even when a bill has passed, then you have the judicial branch that can still challenge what's going on there. All of these people have a role in government, the federal government, the state, and the local government, and these are all components for public health policies. So the federal government is really passing broad laws across the state. And of course, you know that once the federal government passes a policy, then it doesn't really matter in each state. It's something that can apply across the 50 states in the federation. But state laws are dependent on states to pass, and then state have police laws, and so they pass their own laws in the state, and the local government has home rule authority, and they can regulate what's happening in communities when those laws are not specified at the federal or at the state level. So another task for public policy is to establish goals and timelines and funding alternatives. And that's really when you look at the public policy and planning. We do this because we think that everybody has a right to health. So what do you think a right to health means out of all of this one? Do you think a right means everybody has a right to be healthy, or the government should establish resources, or A, B, C, D? Let me go back to chat and see what people are saying. My chat is flickering. Oh my goodness. Okay, B, B, C. I'm seeing a lot of B, C. Yeah, the C's are correct. So as much as we will say that, you know, government should establish this even if it lacks resources, it's really that it should look at accessibility, healthcare for all. That's the responsibility for government. So it's not that everybody must have a physician. It's that government has a responsibility to make sure that you're passing policies that are putting everybody within reach of healthcare. So that's a C for that one. So which US agency has responsibility for coordinating the health of Americans? CCC, AD, ADCC. A is actually, National Institute of Health is actually part of the Department of Health and Human Services, and the Centers of Disease Control is also part of this, the Department of Health and Human Services. So C is actually, we know World Health Organization is in charge of the world, not for the US citizens, but in terms of in the United States, it's actually Department of Health and Human Services. And the Department of Health and Human Services has a number of agencies under it. This is not an exhaustive list, but it actually takes care of the entire American population through various administrations and agencies. So the CDC, the National Institute of Health, Food and Drug Administration, SAMHSA, are all under the broad Department of Health and Human Services. And now we have some other health issues. As you can imagine, housing is healthcare. It's one of the things we say. So Department of Housing and Urban Development also has an impact on the health of our community members. And the Environmental Protection Agency, which is in the Department of Interior, also has implications for health policies. So these are all people that we work with. But we also have different health acts over the years that are policies that have implications for the health of the population, and their ongoing Social Security, Medicare, Medicaid for low-income people, for elderly people, White Care Act for people living with HIV. A lot of programs are funded through the Violence Against Women's Act, Family and Medical Leave Act, allow people to take time off when you've had a baby or there's a medical emergency in the family, the Trafficking Victim Protection Act, and the Affordable Care Act. All of these have passed. And all of these are in one way or the other regulating the health of members of the community across the country. In health policy, you also have to be able to defend, what existing health policies, program designs, and this is based on what the CPH and APHA call the iron triangle. There are three key things that are key factors for really deciding how to evaluate health policies, programs, and resources. Anybody wants to give any option, any idea about what are the three things, the three main areas that the iron triangle focuses on? Access, quality, and cost. Way to go, Leslie. Way to go. Absolutely. Leslie has already given us the answer: access, quality, and cost, and everybody's yes. Okay, so access, quality, and cost. And when we talk about access, quality, and cost, what are we talking about? We need to have access. Everybody needs to be able to have access to the services that they need or the resources that they need to be very helpful. But this doesn't always happen. Why doesn't this always happen? Because we have barriers, and some of these barriers may be geographical, and maybe transportation, maybe financial, personal conflict. So you say that you're providing health services, but hospitals are only located in certain areas so that people don't have transportation to go to them. People have to pay co-pay or out-of-pocket expenses, and they do not have the financial resources to actually access these services. Or personal conflict. The people who actually have insurance and say, I can't take time off from work, or people don't have insurance and say, I can't take time from work. But when we're looking at policies and we say that we're providing health services, it's not just to say we provide services. We have to be trying to address all of those issues as well. Can people get to them? Can people access them? Can people afford them? In addition to accessing them, there's the question of quality. And according to the World Health Organization, quality is the extent to which healthcare services provided to individuals and patients improve desired health outcomes. In order to achieve this, healthcare must be safe, healthcare must be effective, healthcare must be timely, must be efficient, must be equitable, and person-centered. And this means that we can't have populations, we should not have populations dependent on emergency room services, because that is not effective, that's not timely. We should be able to get them, when people are sick, they should be able to access the services that they need when they're sick. And when is it safe? Is it effective? Do we have one system of care for one population different from another system of care? It should be the same quality for everybody, regardless of where they live or work or play. And then the cost is focused on affordability. For a lot of people, healthcare is really very expensive. Very expensive. People have gone bankrupt because of hospital bills. I know that many times I've had people say, if anything happens to me, do not call 911, okay? Even if you have to drag me to the hospital, drag me to the hospital. And that's just the first of the expenses. Paying for the ambulance and the 911 service. Then when you get to the ER, it's completely a different care of service. Now, the effort to address this was done by, again, a policy issue in 1986. the Emergency Medical Treatment and Labor Act. And this policy says that anybody who comes to the emergency room has to be treated regardless about whether they can pay or not. The downside of that, people have said, is that this is an unfunded mandate. So the service providers don't necessarily get paid. Even though they have to treat these people, they don't necessarily get paid. And so the people who actually can pay for services are premium services, because this is a mandate, but it's an unfunded mandate. So if this was a funded mandate, then it would be less expensive to access emergency service. But because it's an unfunded mandate, people just don't want to go. But when we're thinking about healthcare, we have to be thinking about the entire issue. And so when you're thinking about healthcare, you have to be thinking not just that the hospital is there, but how can people get to this hospital service? If somebody doesn't have housing and you're giving them medication, how do you want them to take their medication if they're living on the streets? People need to be working. They can get health insurance from work. What's the nutrition that people have access? Somebody who isn't working or who doesn't have money is not going to buy all the food that you think that they should buy. And so when we're talking about health on one, we have to be working at the policy on many levels and not just on one level. And does it lead it to tier service? Sheshadri, I don't quite understand the question. Does it lead to two-tier service? I don't quite understand the question of if it leads to two-tier service, but we're just saying that when you're working, you have to educate people on all the decisions to improve services, and then you have to be tying it to social justice and equity. So we see some health policies have tried to look at the issue of social services. Oops, sorry. Some health quality have tried to look at the issue of social service and social justice and equity. You look at the Ryan White Care Act, we're looking at mothers and children, including children with special needs. So if without having, Medicaid for all of this, then we will have people who are vulnerable and who can't afford services. Ryan White HIV/AIDS care. Especially in the beginning of the HIV epidemic, people couldn't go to work with HIV, and so if they didn't have these programs that were funding and taking care of their health, how would they have survived? And so we have demonstration programs, waiver programs that states put in place. They can do and show how they can provide services, and they can get funding from government to provide all of the service if they treat anyone regardless of their ability to pay. Oh yeah, so it was Sheshandri was clarifying for me is this: if they treat anybody regardless, you have to. So according to that, the law that passed, the Emergency Medical Treatment and Labor Act, you have to treat everybody who comes to the emergency room regardless of whether they have. Now, what happens is you can get treated and get a big fat bill after you leave the emergency room. The people who have insurance, though, get billed almost because all these other costs, again, like we said, this is an unfunded mandate. So the cost is spread even because the providers have to be able to provide the services. So they charge everybody across board, but you cannot get refused. What this just means is that you cannot get refused services if you go and say you don't have insurance. You cannot be refused services in emergency room because you don't have insurance. They're not providing you substandard services, they're providing you the standard services that you should get. It's not that you get one kind of service if you don't have insurance, you get treated, but it's just that it's not a funded mandate. There's no guarantee that the service providers will be paid for the work that they do. So that's a lot of information. We'll take a 5-minute break now, and we'll be back in 5 minutes. If you have questions, I'm here, I'm not going anywhere, but if you have questions and you want to do that, if not, you can take a 5-minute break. It's their timer.
So
Ashley?
we'll be back at 3:50 then?
Yes.
Okay, 3:50, everyone.
Slides are available, yes. I think the slides will be emailed to participants who registered for it, Grant.
Yeah, so I'm sending out the recording tomorrow. The slides are not in the recording link. We're not going to send out the slides right now. So you will get a link to the recording, and then I will talk with the rest of our team about the slides. I've seen a couple messages about it, so I will talk to them and discuss where we can put them for everyone. Then I see you have a question about the type of exam questions. We are going to go over some practice questions at the end of this session. So you will see some practice questions, and these are old questions that used to be on the exam. They're retired questions. So the ones that we've been going through are similar, but that will be some more review for you. And these sessions are 2 hours long. So they are recorded, as I mentioned at the beginning. So if you have to leave or you missed a part of it, you will get a link tomorrow with the sessions. Okay, I'm going to answer a couple questions while we're waiting for Dr. Agbeyegbe to start again. You do not need to stay the whole session to be eligible for the practice guide raffle. Anyone who has signed in, I have your information. So if you need to drop off for work reasons or personal reasons, that's perfectly fine. This class is to help prepare for the exam. Each session will go over a domain. So the initial session last week was to go over the just the overall certification logistics, and each concurrent session will go over one of the 10 domains on the exam.
Great. And just one minute more. Awesome. Oh, this is the old slide. Okay, sorry about that. Okay, great. So welcome back. So we'll be looking at health policy, and we said, we have to plan our policy issues, identify the problem, make sure that the solutions include the policy issue, work with stakeholders, get a policy to pass both houses at the state or federal level. And then once that policy has passed, look at the implementation, look at the evaluation, and then see what we can do about it. We looked at the triangle of saying when we're looking at health, which is a right for everybody, we have to be looking at access to health, the quality of health that people are, and the cost of it, that it's affordable. Well, all of this is largely dependent on using scientific evidence, best practices to support all of this data. So when we want to say this is the policy that we should be looking at, we really need to have the evidence base behind it. And so that's why we have to be collecting data, and we have to have colleagues that are analyzing the data. And then based on the data has been collected and been analyzed, we have all those stakeholders together who can come and say, this needs to change. This is what's going on. This is why this is wrong. This is what needs to change. And in order for this to change, there's this policy that has to be in place. There are different people. Some small organizations collect data on their own and they use it to fund, they use it to inform their program strategies. So when they're doing your 3-year strategy plan, 5-year strategy plan, they've looked at data on a small scale. But on a national scale or across the country, we have some large databases and that people can go and access information. And this information is informing policy at the state and at the federal level. So we know the CDC really has policy by state for prevalence and mortality. Robert Wood Johnson, working in collaboration with the University of Wisconsin, has county health rankings and roadmaps, and people use that to say, okay, this county has this, in these 3 areas, this county is not doing as well as other counties in the state, or this as other counties, and use that ranking to say, what policies do we need to change? We have the Guide for Community Preventive Services by the Health and Human Services, and they provide evidence-based information in terms to effectiveness. You know, one of the things we talked about when we say the policy is not so much of the fact that you pass the policy alone, but is like, is it effective? If you say people should turn in their guns, are you actually able to get guns from people? You know, if you say that there's a safe exchange center, how easy is it to find a location that is safe? And what's the cost of implementing that policy? Is it too astronomical? Do you need 1 or 2 centers? What are you doing to do that? And then there's the National Guideline Clearinghouse by the AHRQ, and they look at practical guidelines by topic areas. So we're looking at, you know, where do we stand with maternal mortality? Where do we stand with vaccination? Where do we stand with cancer rates? And all of these policies. And looking at all of this information is helpful in deciding what policies you want to pursue and what policies you want to reverse. In addition to policies as well, this is important for us. This is another policy thing. So you have to access position of key stakeholders. Again, which was why I showed the MLAW brochure that had all of those different partners. When you want to work in collaboration with partners, you have to bring people together and say, okay, fine, what do we need to do? So everybody collectively coming in, you're thinking strategically, you're organizing it, you're being strategic and saying, okay, fine, here's what the data says, and here's what the priority is, and this is how we're going to intervene in it. You know, I've worked in the field of HIV/AIDS, like I said, and sometimes we looked at the data on HIV/AIDS and we're saying that, okay, fine, in New York City at that time, we do not have a high mortality rate of HIV/AIDS, but that's because they were providing service to people and people were living longer. But as people were living longer with HIV/AIDS, though, it meant that we needed to provide other support for them. So we're working more with HUD to say, how do we get housing, upward housing for people living with HIV/AIDS? It's important for them to be housed, because when they're housed, they're not on the street. They cannot practice harmful behavior that can allow them to develop drug-resistant HIV/AIDS. You want to work in collaboration also with nutrition and food bank and make sure that they're not just providing them food because it's a food bank, they're taking into consideration their health issue and providing healthy meals for them. So this MAP strategy that was developed by CDC and NACO is a strategy that people look when you're thinking about bringing partners together to work on a health issue. Now, another task is to promote the adoption of healthy policy programs and resources. So when you work, you know that this is what's going to work. You've talked to your partners, all of you have come together, and it's like, yes, this is what's going to do. It doesn't work automatically. You have to come together to say, okay, who am I going to talk to about this work? And that's when you do policy. You have to go and advocate to people. You have to lobby people, and you have to work on earmarks to it. I think I'm missing a slide. No, okay. So when you're looking at assessing the positions of key stakeholders for the health policies, you're looking at different key stakeholders. Sometimes we want to work with, a lot of you may work with government organizations, and then these are the key partners that you want to work with. But sometimes you may work with smaller organizations and you're working with your partners. But if you're working at the government organization, then you have to follow this kind of laid out principles. The National Public Health Performance Standards, they have laid out guidelines for what we should be seeing at that local level. The State Public Health Assessment, the Association of State and Territorial Health Officials, they have their work, and they're able to form, you get there's that thing that says if you want to go far, go alone, but if you want to go well, you go with others. So you have all of this planned approach to community health by the CDC. What they do is they plan and they look at things, and they're able to look, because of the data that the CDC collects, not just at a individual level, at an organization level, they're able to collect this data, and then they're able to advocate more for it. So you're working with stakeholders, you're finding out all the people who are working in programs and bringing them together. Now, when you look, this was the slide. Okay, here's the slide I was looking for. It wasn't, I think. So when we look at advocacy that I talked about, you advocate at the local level, at the state level, and at the federal level. And advocacy can be done by ordinary citizens like you and I. But beyond you and I, you can also work with members of your community. So you have people that you're serving if you're providing direct services. If not, you tell the members of your community to write letters, to write emails with their elected officials. You organize, my office used to organize meetings with our constituents. And when we were in New York, we'll go to Albany to our elected officials, or we'll go to Washington, D.C. to see, then it was Senator Schumer and Senator Clinton. And we'll say, fine, you do put oral presentations and written testimonies. You have people who say, I'm somebody who's living with HIV/AIDS, and I went to the hospital and I couldn't get service, or I couldn't get housing. I'm somebody who is a victim of intimate partner violence, and I have a restraining order, but my ex has a gun and has used the gun to threaten me. So that's what you do for advocacy, and that person is going and is testifying and saying that, if you don't change this law, I'm going to be at risk. I've given testimonies. I think my last testimony was at the DC Council, where they wanted to pass a domestic worker bill of rights, to say that if you don't pass this law to protect domestic workers, then they're at risk for exploitation that can put them at risk for trafficking. And I did that based on my work at Polaris, because we had data that showed us that people who were being trafficked for domestic workers were being trafficked by their employers. And so employers did not have clear guidelines. So if you have a domestic worker bill of rights that provides clear guidelines for employers, then they cannot exploit people and they cannot traffic people. So you can do advocacy as your work. You can have your partners go and testify. You can have your data to show. And that's why we looked at the data collection earlier. It's very important. And you can have people who have personal experience also go to give these oral presentations, these written testimonies, to say that this is the policy that we want to change. Now, in order to get policy change, also, there's another aspect of policy adoption that's called lobbying. And this lobbying is done when you're doing lobbying, when you're actually communicating with a policymaker or staff. Now, when you're doing advocacy, it can just be us. We can talk to ourselves. You want to communicate with the other, but we educate ourselves on how to go and lobby. When you're doing lobbying, you're communicating with the staff, and it's particular about, there's a particular law that wants to go past. So now people want to do, they say, you need a mental health examination for before you buy a gun, or who should own a gun. And there's a particular law that's being proposed, and people are on both sides of the divide, So you want to tell this person, vote for this law or don't vote for this law. So you go and engage your elected officials directly. Grassroots lobbying is when the people who do it are members of the community. However, we also have registered lobbyists. So there's this big, and I'm saying gun because gun is a very big public health thing, and I don't know why I can't remember them now. The big gun lobby group, they have registered lobbyists that are working for these companies. So even when you look at medication, yes, the NRA, absolutely. So they have registered lobbyists who are like right there at the federal government, right there at the state government, and they are saying no, don't pass this policy. And they also gather their own data. I know when I worked once on policy for alcohol industry, and they were like, oh no, it's not selling it's not selling alcohol to underage people that makes them at risk. It's how the parents bring them up. Like, okay, so if it's not selling alcohol to young people, why are you so intent on marketing alcohol on campuses if you think that your product doesn't have any impact on them? Why you emphasizing, why do you have marketing strategies that are targeting young people? So, but the registered lobbyists have their own data, and they're going to go and try to lobby their own thing. But we see how far they could get with the tobacco smoking. They have to put the warning on their tobacco packets now because that's what they're required to do. But you have the registered lobbyists that are working on that. And then another part of really getting people aware is earmarks. So earmarks is something that comes out of funding, the specific projects that you want government to fund. And when you're lobbying it, so you see the time where people are lobbying for policy, but they're also lobbying for earmarks, because a lot of times you can get the policy passed and there's no funding to implement the policy. So that becomes a problem when there's no funding to implement the policy. So you have to say, yes, give the Department of Health this much money, give the Department of Housing, Transportation, this Department of Education this much money. It's very important to give all of these monies as well to people. That's how you promote the adoption of health policies and resources. Is there a question I missed? So let's look at this one example, and this is another chat response. Let me see what people are saying in the chat. Following the clinical trial, a pharmaceutical company hired a firm to advance the approval of this. Which of this following does the absolutely. So a pharmaceutical company is not likely to get grassroots lobbying because members of the public are not so aligned with pharmaceutical companies. What they would have is a registered lobbyist who is representing their interest and can speak for them. So yeah, D is the answer for this one. So now we are on to identifying the social and economic impact of a health policy program or initiative. And just because, there's a policy and there's a problem, you've identified this as a problem, we've said to ourselves that, safe exchange center is an issue because parents are getting killed or children are getting killed during exchange. Doesn't really mean that is what needs to be done. You have to follow these steps and say, okay, fine, does it make sense? Fine, we said the safe exchange center, but let's look at the cost analysis. Let's look at the cost, direct cost and indirect cost, because you're now saying that we should have a building dedicated to exchanging children custody who have custody with both parents. If we have to get a building, we have to get particular staff. Staff has to be trained. We have to put in specific security in place. What's the location of the building? You have to look at that cost analysis, and then you can see that it doesn't matter what in this particular case, right? You say it doesn't matter how much it costs. If we're saving somebody's life, because we have evidence that some children have been killed during exchange. So yes, this cost, it doesn't really, however much it costs us, we really need to have a safe exchange place, because we just can't have people exchanging children anywhere. So you have to do the cost analysis. Beyond the cost analysis as well, you have to do a cost minimization analysis, which looks at two different interventions. Can we just have them exchange the children anywhere, but have them trained on anger management, and conflict resolution? Will that be enough, or do we actually have to have a safe place? Look at two different interventions and say which of them is most effective. You have to do a cost-effective analysis and say, okay, fine. So if we train the parents on anger management, and we train them on conflict resolution, does that guarantee that children will be safe when they are exchanged, or is it a safe space? What is the cost effectiveness analysis? You have to look at what you are doing. Conduct a cost utility analysis as well. And what is the outcome measure in this case? If you are saving lives, and including social functioning, what you have to do all of that analysis, and you have to do good old cost benefit analysis, giving the amount of money that we're putting in, what are we getting out, and how helpful is it to us? So these are the steps that you have to go to if you want to look at the economic impact of a health policy. Another task that we look at is to analyze the political, social, and economic policies and how they affect the systems. So you have to look at the laws and the regulations, the executive office, the executive orders, and the judicial decisions. And sometimes you can just think that, yes, you're in a place, you pass all of these laws, but they can change over time. People can come and people are saying, this is where we are, and what do you need to do? So if we look at some of these things, for instance, that have passed, we know that Roe v. Wade had passed at one time, but then how does it affect the health systems at the local and government level? Across the states, you have different states now have passed various abortion laws, and it's in one place. You can do it in one state, you can't do it in one state, but you have to see that, can you get countrywide approval, countrywide buying, or is it going to be different, which is what we have seen. A couple of years ago, the US withdrew from the Paris Agreement. What does that mean for us as a country? So how many states are now beholden to implementing climate safe policies in their states and in their local government? So these are all of the things we have to do when you're analyzing, when you're doing a law, that yes, you can pass a law, but what's the implication, and how far can you go, and how long will that law live? Not just even passing it at one point in time, but really what's the difference? So let's look at another question. Which of the following is most important to address in climate change policy in terms of its impact on population health and health systems? What do people think? All E, 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 A, E, E. Well, I think this one, we said that, you're looking at population health and health systems, and if you look at I will go for all of the above, really, because if you look at it, if you look at the economic factors alone, you're not looking at the political factors. You have two different parties saying that the scientific factor is not sufficient in itself, because there are a lot of people who say the evidence is lying. So you can't just take the evidence alone. It's not going to work. You can't, the evidence is also tied into the economic factor, But that alone is not going to work because there are people who are not impressed by all of the fact that this is it. So you need to take that and combine it with the political factor and also combine it with what's going on in the world. So, and that's why I would go with all of the above. So when you are also doing policy, you have to measure changes in the health system. You have to use input, process, and output. So how much resources are you putting in? How much human resources and financial resources are you putting in? What process are you doing? And how is that saving lives? If I decide to form a new department and I say, okay, people are not turning in their guns, I need to expand the work that the sheriff's department is doing. I need to have them have somebody in the courthouse. I need to make sure that when somebody is, convicted of a domestic violence offense, they know they need to turn their guns in, and then the sheriff follows them or make sure that they turn the guns in. All of those things I'm putting in the process. How many lives am I saving at the end of the day? And is it really saving lives? And if it's not saving lives, then it's not something that you want to do. So you have to be able to look and say, what are we putting in and what are we getting out? What are we putting in and what are we getting out? Now, a lot of effort was put into the Affordable Care Act. It was a big policy issue. And what we've seen after the implementation of the Affordable Care Act is that, yes, we had more people have been insured, right? More people have been insured. People were supposed to expand the Medicaid, but it didn't happen all over the country. If you look at this map, 31 states expanded the Medicaid, but we have states that didn't expand Medicaid. So it seemed like a no-brainer policy. It seemed like a policy that would lead to an increase in the number of people who have insurance. But because it was very political issue. Remember, we talked about the window of opportunity, and we have some people who have political difference. Not everybody, even though this is supposed to be like a good thing, not all states adopted it. So you have to see that there are different positions, and then you say, when you're proposing a policy, how far is it going to go? How many people is it going to benefit? And is there going to be uniform is the policy going to be adopted universally across the country or across the state? So you have to analyze policy options also when you are designing policies to say, okay. And when you're thinking about policy options, a lot of policy makers look at the models, frames, and theories that are out there. What's the evidence based? Does the evidence support that if you mandate things, for instance, will people do it? Does the evidence support that you should train things instead? I remember in Maryland, we wanted to address teen dating violence, and somebody said, don't do policy on legislation because people won't do it. And so what we did instead was we created a healthy teen dating guide that we introduced to the state. And so there's a website where you can go and get this healthy teen dating guide. And it says to people, these are programs that you can implement in your county. This is how much it costs. This is how many hours it will take. And so you can go there and take the one. If you don't have money, there are ones that are free and there are ones that cost. If you don't have time, there are ones that are for a week, there are ones that are for 6 weeks, and they have different things. You just have to have the different policy options and put those things there because that's what will help people look at it. You also have to be looking at what's the impact of this policy that you're about to introduce. Are there intended and unintended outcomes? Are you going to make people run in the shadows? I know that one of the policies that we've had struggled with was domestic violence and creating policies that make immigrant population not want to come forth because then became the policy of whether they're going to be reported to immigration. So even though your intention is to make people, domestic violence victims, feel safer, if they are going to be reported to immigration and then people are concerned about whether they're going to have to leave to go back to countries that they feel that it might be unsafe for them, maybe that's not the policy you want to pass. So you really have to evaluate what all of this is, you know, when you're looking at policies, and then really be thinking about before and after. What's the difference in if you didn't have this policy before, what was going on in your community, and what will happen if you introduce the policy? You know, what can people do with the policy? What can people do without the policy? What's the actual versus planned outcome of the policy? So when you look at those things in that light, then you can evaluate and determine whether you're going to implement the policy or not. Another way of analyzing policy when you're looking at that way I said was for programs, but there's also the congressional approach. So congressional approach, the way they approach policy options is they look at the budget office, they look at currently what's the cost that they have and how is this new policy going to impact them. There's also the Government Accountability Office, which is an independent and non-partisan office. So it doesn't matter whether you're Republican or whether you're a Democrat. What they do is they provide fact-based information to Congress and say, look, based on what we have said, this is not whether we're Democrats or not. This sort of programs, this is what the evaluation is saying about this sort of programs. And actually, we found out that this program already exists, or you know, you can save money if you implement this program like this. They provide all of these guidance to Congress to say whether Congress can adopt a policy or not. This information is helpful at the congressional level. Another task is to ensure the consistency of policy into organizations, plan policy procedures and structures. And what does this mean? That means that when you're designing a policy so that there's consistency on all the organizations, I know when we talked about the turning of the guns, for instance, we wanted to find out if you pass a policy at the state level, is it working in all the counties? Or is one county doing it better than the other county? You know, and so what's the change? What's bringing about the change? Why are you seeing different outcomes from all of them? One way for policy in integration is really, there's no policy you have, it depends on funding. Depends on funding. Are you getting new staff? Are you getting new capital resources? And these are the committees, both at the Senate and the House, that have oversight of funding issues. So when you're looking at the news, for instance, you look at the people, the ranking officers that chair these committees, and they are very big because they make the decision about how many million and how many billions they're going to be giving to any policy that is funded. And just like we talked about the emergency room service, that is an unfunded mandate. If you pass a policy and there's no funding behind it, then people cannot really implement it. You know, so you don't want to do that. They say half bread is better than none. So yes, it's good to have a policy that has been passed. But the best way to make sure that the policy that you pass is going to be integrated into plans and policies, it's actually going to be implemented, is to give them the financial resources to be able to design and implement the program. So how do you implement these programs? You have to have stakeholders. You have to have everybody at the table. I think somebody was saying earlier on that there's a discrepancy between the people who design policies and the people who implement it. And that's when you have issues, because you can look at the data and the data can tell you that this is what the crisis is. The data may not tell you what the solution is, you know. And then you also have to make sure that you're doing both qualitative and quantitative research. So not only telling you what the problem is, it's the people in the field will tell you how you can implement that problem, what can work. And this is where you need various stakeholders to be involved in the process. People have to have different roles and responsibilities. You know, people have to be monitoring the implementation to see, is this working as we designed it to work? Are there some unintended consequences? What do we need to do differently? And these are factors for whether all of it was worth it in the first place. We know, for instance, some policies have been worth it. If you look at the tobacco industry, for instance, and bringing all the stakeholders together. So we know that we have increased the age of how somebody can buy tobacco. A lot of you may be old enough to remember where, you know, people smoked on the plane. People smoked in all the restaurants. You know, now you go to restaurants, some restaurants have smoke sessions, some restaurants don't even have smoke sessions at all. Some people can't smoke. I remember when I was working in Staten Island, at first you couldn't smoke in the office. You had to go downstairs, outside the building, and go downstairs to smoke. And then 2 years into that, they actually made a policy that you can't smoke on the block of our office. So you have to go around the block to go and smoke. So you have to have all of these stakeholders coming together and say, okay, this is implementation. They were offering people to participate in a smoking cessation program. So it wasn't that they were just saying you can't smoke and then you were on your own. You all had the option to participate in a smoking cessation program to help you get to become a non-smoker. But all of these things, you have to look at it and look at the intentions and how the program is working. So when we make all of these policies have to be enforced. There's no point having policies and there's no enforcement. And enforcement is done by the relevant agencies and the Department of Health and Human Services, but sometimes we talked about HUD has HUD, and the Interior, which has the Environmental Protection Agency, have some health-related programs. So, for instance, the FDA enforces provision of sale and marketing of tobacco to minors. Excuse me, and they're the ones that insisted that you have a health warning on tobacco packet. So aside from in enforcement, we also have compliance. You get compliance by training, education, surveillance, and penalties. So if you tell them, if you don't do this, you get a warning letter, you can lose your house, you can lose your assets, you can lose your opportunities. But we also do education and training. You are certified in public health. Some of you can offer trainings to say, okay, fine. When you have a child in custody, this is how you exchange the child so that you are not violating any law. So you do the enforcement, the agencies do that. The compliance is done by us. We educate and we try to get people to understand what the laws are and why people need to do it. And then the state police powers. So the state has licenses hospitals and clinicians, and if they are not doing what they want to do, you know how it is. You can lose your license. You can't practice in this state anymore if you do something that is impacting people's health negatively. You have to go to another state to practice. And then home rule authority is local governments have the ability to enact ordinances and regulations. So this, in a nutshell, is policy formation. You have to find a problem, find a solution. So everything that we have gone through is really in 3 phases. Where there's a problem and you say this is a health problem, you look at the solution, and there's a policy issue. We have to make it hard for people to buy cigarettes, hard for people to buy alcohol. We have to prevent people from smoking. We have to make sure that people can get access to testing for vaccines, whatever it is that the policy is. If there's a policy opportunity, then you look for the window of opportunity and say, okay, fine, everybody's talking about I don't know, everybody for instance, when George Floyd was killed and there was a lot of work about DEI, a lot of people were able to get DEI initiatives passed during that time. So you say, where's the politics at, where the people are, where's public opinions are? Can you get people to write letters? Can you get people to go to talk to their elected officials? Can you combat the lobbyists? What can you do that? And when you do all of that, you form a legislation, then you begin to go and talk to your elected officials to make sure that they pass the bill, or you meet the people opposing the bill. If that bill is passed, it's not passing a bill is not the end all be all. You have to make sure that the bill is actually implemented, and then when the bill is implemented, you have to be monitoring the bill as well. One, because your opponents are also monitoring the bill. Your opponents are monitoring the bill, and they can come back and say, you see, this is why we oppose this bill, because nothing has changed since this bill was passed. So it's just a waste of government funding, or it's a waste of something or the other. So you also have to be monitoring the bill, monitoring the policy, to be able to say, wow, this policy that we see. This was what was going on before we passed the policy. Now that we've passed the policy, this is what has changed in our community. Therefore, we should continue to pass this policy. Another country, another state, another county can come and say, well, this is what they did in that county when they said people should pay taxes, and when they said people should pay taxes on paint, and we use that tax from paint to offer home-based asthma services to members of our community. We're able to increase the homes that were lead-free in our community. So we want to do what that county did as well, so that we can have more homes that are lead-free or asthma safe in our community at all. So that, in a nutshell, is the process for policy in public health. And yes, it's now time for the practice questions. Ashley, sorry. So, are you deploying the questions, right?
Yes, I will.
Okay, awesome. So stop sharing.
Yeah. Do you have the slides with the questions on them just so they can see the questions as well? Yeah.
Okay.
So we'll do each one individually. So we'll go question by question.
Okay.
All right. Now leave this open for about a minute, just so everyone can see. And the question is, the first step in policy process typically is? Was it out of order?
No, it's I don't know how I came out of it.
So, okay, there we go. All right. I'm going to give you
the poll.
Yeah. Okay, I'm going to end the poll. We have 90% answered B, problem definition.
Absolutely. And B is the correct answer. So yay. Okay.
Right.
And the next.
So this is, which of the following practices enhances equity across populations when making health policy decisions in a community? All right, just 10 more seconds, everyone. Get those answers in. Okay. So this one, it looks like D was a little, but we have about 30% who are saying C.
So if you collect health-related data from individuals in the community, the question is, which of the following practices enhances equity across population? So enhances equity across populations when making. You have to include a diverse constituents in the decision-making group, because it's that diversity can inform the data that you collect. But just because you're collecting health-related data doesn't mean that you have diversity in it. And if we're talking about health equity, then our primary focus is on the diversity of the population. And so the answer is D, actually.
All right, question 3, policy analysis when designing public health programs is? Pauline, I do see you have your hand raised. If you want to type in your question in the Q&A section, we'll answer that. Ten more seconds. Okay, this one. We have the answer was C. Majority, 81% said C.
Yes, the answer is C. Policy analysis is not straightforward, you know, and it's not subjective as well. It's not impossible. The thing is, it's complex. You have to have the data collection. You have to be working with diverse stakeholders. You have to strategize how you're engaging both houses. You are looking at the policy design, at the bill passing, at the implementation, and at the execution. So it's really a complex process.
Okay, so this one. CHIP is a federal program that has been important for public health because and more seconds. Okay.
Yes, absolutely. It is preventive services. It provides both to support state health program. That's the primary reason why it's important, is because the people who otherwise will not have access to them. And we said that health is a right. Government should be providing health to other people. It's not funding school health initiative because we have children who are homeschooled and are not in school. They have a right to health insurance. It's not the fact that he remedies the difference between character. It's the primary thing that these are population of people who ordinarily, if they didn't have access to this program, would just not have any access to healthcare at all. And last question.
All right, question 5. The focus of public health policies, programs, and resources are. We did have this one earlier, didn't we? 10 more seconds.
Absolutely. So even though lobbying, advocacy, and MAC it's a way in which those are avenues in which you get it done. But what you're actually focusing on is you're lobbying because access, you want to make sure everybody has access. You want to make sure that the quality is good. You want to make sure that cost is available to everybody. You're trying to change those policies at the federal and state and local level. But the real focus is access, quality, and cost. We can do that. We can get to that through lobbying, advocacy, and MAC at the federal and state level. But C is the correct answer. So awesome. So I wanted to end with this quote from a past president of the American Public Health Association. She said that, public health is the right group to bring stakeholders to the table to positively impact the social determinants. We in public health are collaborative by nature. We can't do this. We're working on health issues. We are conveners. We understand the power of synergy. We are the right people to change the way we as a society approach health. You are those leaders. So thank you very much for pursuing your certification. I wish you the best of luck. And yes, thank you.
We did have a couple questions I just wanted to go over.
Okay.
So if anyone had questions, just please put that in the Q&A. The first one was, I think has to do with one of your slides, but it was about the PACs. It says, why was that one not PACs? Pharmaceutical companies have their own PACs that hire lobbyists on their behalf.
Okay, so it's a question about the pharmaceutical. It's because they, and I'm trying to go back to that slide. The pharmaceutical companies, yeah, this is it. We don't consider pharmaceutical companies to have the way the pharmaceutical companies can influence decisions that are being made is through their lobbyists. They hired a firm. The political action committee is not a firm. That is, the lobbyist is from a firm. They hired a firm. So this is what it says. The pharmaceutical company hired a firm. The political action committee, PAC, is working collectively of this, but this is one firm that the pharmaceutical company hired to work on it. So it's that lobbyist that they're working on.
Okay. And there's one other question that says, does the CPH exam test on your knowledge on specific legislation per the CHIP question? And is there a list of which ones we need to know about?
Well, I'm not writing in the questions, but I don't think he tests on your particular knowledge, but he wants to know that you understand the factors that can influence in this particular case, for instance, so if you have question about CHIP, for instance, it will be that you understand that health equity is an issue and CHIP is providing services for underserved population. That's the sort of thing that we want to see. That are you knowing? So if you have the examples of all of these policies, for instance, and you want to be looking out for, is it addressing something like social determinants of health? So if we look at, if you ask questions about the Affordable Care Act, for instance, it's really to say, and you want a policy question, it's really to say, under what climate did it pass? Do you understand that the Affordable Care Act could not have passed if it was dependent on political ideologies, because Republicans on one side when Democrats was on one side. So it's not so much of one particular policy question, it's the factors surrounding the Medicaid, or the fact that, Medicaid is trying to help seniors, Medicare is trying to help seniors, Medicaid is trying to help unemployed people. Why did Affordable Care Act? Why did we need it? What are the policies that change? Who are the partners that are involved? I don't think it tests the particular knowledge of a question. It's the factors. It's kind of like that last question where we said it was, it's not looking at whether you understand lobbying action. Do you know that the focus is on access? Do you know the focus is on quality? Do you know the focus is on cost? And how is this addressing any of those issues?
Okay. One more question. What is the name of the policy change model used by CPH? Polaris?
What is the name of the policy change model used by CPH? CPH as in Certified Public Health Educator. There are different policy change models that people use. Let me see where I have different policies. Everybody uses what works for them. You use different systems in your organizations. And I'm trying to see. I have that. But we use different methods anyway. So let me see if I can. Oh, it's right here. Okay. So the mobilizing for action through partnership, planning and partnership is one model that a lot of people use. That's community mobilizing. You're using data, you're working with organizations, and you're selecting health priorities. So this is one common one that a lot of people use. Another one that people use is this planned approach to community health, and some people use planned approach to community health. It just depends on what you're working with. But you can also consult with the Association of State and Territorial Health Officers, NACO. All of them have policy issues. Different people use. So the slides that I showed you at the beginning, for instance, of and I don't see them anymore. Okay. Yeah. But different people use different policy issues. You just have to find the one that works for you. But the important thing is the fact that you should be able, this is the important thing in this last slide. So this is the important thing. You have to be looking for your window of opportunity, right? You have to know what your possible solutions and what the political circumstances is. And you have to have your different stakeholders. So if you have your different stakeholders, you know that one of your solutions is a policy issue, what the political circumstances and the window of opportunity for you. Then you can galvanize all your partners to make sure that you can work with them to advocate for a policy change.
Okay, it looks like that is it. All right. So everyone, thank you so much for attending today. The recording will be available tomorrow afternoon. You will get an email through the webinar portal. So just like you got a link today to remind you to come to the webinar, you'll get a link that says thank you for attending, and that will have the link to the recorded session in it. We hope that you can join us for our next session, which is this Thursday, and the topic will be communication. So once again, thank you so much for your time today, as well as thank you, Dr. Lillian Agbeyegbe. Sorry, Agbeyegbe. Thank you so much for your time as well. And
thank you so much. I want to say, Mallory, I saw your comment and I think that that's very helpful. So Mallory was talking about the comment about PAC, and PACs are usually related to fundraising. And she said, yes, she'll have been drawn to PAC if it was fundraising, but it was policy issues. So that's another thing to know, the difference between PACs. Lobbyists are lobbying for laws. PACs are doing, terms of fundraising. So that's one thing to note. I think that was helpful, Mallory. I think that was helpful. And then Jody, sorry, said, you say problem definition followed by proceed planning will be a good way to address the overall process. Absolutely, absolutely, Jody. You can use a proceed model in identifying the problem, as long as when you look at your solutions, you see a policy option in the solutions, and then you have to come now and then follow looking for your window of opportunity to address it via policy. Thank you all. Good luck.
you.